Um, he's professor and director of research at Marshall University now. And I looked up, and this is a little bit crazy, but I read that you have over 90,000 citations on Google Scholar, which is pretty amazing.
Dude, very
Uh,
proud of that. Yes.
yeah, so hopefully you'll be able to distill some of that ACL wisdom into us tonight. And thank you for doing this. Thanks for taking time and take it away.
Thank you, Simon. I appreciate it. So, I'm going to talk to you tonight about biomechanics of ACL injuries, an approach we've taken to reducing the risk. This is Carmen and Katie. They're my two academic daughters. They're both professors at Ohio State University now. And Carmen on the left is a PhD, MD, and Katie is an PT PhD. And they were in what I'm going to show you, our prospective studies at age 17, and they subsequently ruptured their ACL, both of them. Carmen on the left ended up having 11 surgeries on that knee. And the problem is, this is them receiving their terminal degrees at age 29, about 12 years later, and they've both had cartilage resurfacing procedures. And the problem is, Carmen and Katie are more the rule than they are the exception. So, this is the approach we take, what we term preventative biomechanics. And we use this system looking at neurology, cardiovascular, genetic issues like ACL injury. I'll show you some of that data. What I'm going to focus on tonight is the musculoskeletal ACL injury and cartilage issues. And basically, what we do is we get the entire medical team involved, from the orthopedic surgeons to the primary care physicians to the physical therapists, athletic trainers, researchers, and we all work together to try to predict and prevent risk of these highly impactful problems. What we use is what I call a biomechanical epidemiologic approach, and many of those citations that Simon told you about were directly related to those biomechanical epidemiologic studies. So very difficult studies to do, and I need to cite the NFL, the NBA, the NIH. They've all put tens of millions of dollars into these studies.
Just look at my schedule just to give you an idea.
And basically, what we focus on is needy populations, underserved, adolescent, female, inactive, obese populations. And these kind of studies, what we do is we bring the athletes into the lab, we test them biomechanically, and then we let them go out and play, and then we follow them over many years. We've followed an entire county school system for over a decade, and then tracked those athletes who go on to injury to see, first of all, what are the predictive factors, and secondly, to take that information and use that to target interventions to hopefully reduce the risk of these issues. Now, exercise is the best preventive medicine there is. We all know this. It reduces the risk of heart disease by 40%, stroke by 30%, diabetes by almost 50, high blood pressure, reduced risk of mortality of recurrent breast cancer by almost half, colon cancer by 60%, Alzheimer's disease by a third, and it's the best pill you can buy. It's better antidepressant than drugs like Prozac or even behavioral therapy. So the American College of Sports Medicine stated a couple of decades ago, if we had a pill like exercise that had all those benefits readily available, we would prescribe it to every single patient. And I suggest that you do. Prescribe exercise to every single one of your patients. And the prescription is physical activity and preventive biomechanics. What are the downsides to this? Exercise does have downsides. There's risk of injury with exercise. So I've studied for decades the risk of myocardial infarction with exercise. Very rare in young individuals, but it's the #1 cause of sudden death in young athletes, mostly due to FHC, familial hypertrophic cardiomyopathy. I'm not going to get into that data, but we'll talk about some other genetic data. Overuse injuries. So we've published a couple studies looking at the incidence of, say, patellofemoral pain in young female athletes playing sports, pivoting sports like soccer and basketball and volleyball, and showed that risk is about 20 to 25% per season. I mean, the incidence is very high. Now, then there are other traumatic sports injuries that are less rare. And one I'm going to focus on today is ACL rupture. I should say it's more rare and more rare than patellofemoral. In the high school population, in young females, it occurs between, say, 3 and 6% prevalence, whereas in males of the same age, it's like 1-2% of the prevalence. And what we've done to look at this problem is we've looked at the mechanisms, and then we've done screenings based on the mechanism of how these injuries occurred. And then we've developed targeted interventions to directly reduce the risk of these exercise-related injuries. This is Rebecca Lobo tearing her ACL, and we'll talk about some commonalities to this mechanism. Again, we'll get into the mechanism in a minute, but what are the long-term impacts of ACL injury? Well, this was a study based out of the Boston group. This was an NFL-funded study where they showed that former players who tore their ACL, as expected, had about a 2-fold increase in musculoskeletal comorbidities like arthritis and knee joint replacement. The interesting thing and the alarming part of this study was they showed that there was about a 50% increase of myocardial infarction in former NFL players who also experienced ACL tears. Perhaps they suggested a systemic inflammatory process has begun with ACL injury that leads to downstream post-anti-inflammatory effects, maybe even surgically related iatrogenic effects. And this, again, highlights the importance of reducing the risk of these problems. So what I'm going to show you tonight is our 3-pronged, evidence-based, targeted approach to this. Mechanism and the evidence supporting ACL injuries, screening and risk modification, and then training with neuromuscular interventions. So if we go back to Rebecca Lobo, probably the best player in the WNBA at that time, she experienced an ACL rupture, and she never really came. She played for a short time in Houston. The reality is within a decade, she had about, this is Kate Webster and my meta-analysis of meta-analyses that we did on osteoarthritis post-ACL, about a 35% risk within the first decade of having significant radiographic osteoarthritis. So how does this occur? If you look at the entire body, what you see is this lower extremity valgus, or what we term biodynamically as knee abduction, meaning the distal tibia is away from the midpoint of the body. We're starting from the foot up biomechanically. She started with relatively low knee flexion. Most of her weight was on a single leg or single foot, and the foot is flat and rotated away from her midline. And then the center of mass of her body is lateral to her foot base. And there's sort of this uncontrolled movement, which was caused in large part by a perturbation at her hip and trunk. Now, if we zoom down on her knee, as we do here, what we see is this combination of knee abduction, anterior translation of the tibia, and internal tibial rotation. So if this is my fibula, basically what you see is abduction of the distal tibia, anterior translation of the tibia relative to the femur, combined with internal rotation, applied simultaneously, very rapidly, pop, within 30, 60 milliseconds or 1-2 frames of a video, the ACL ruptures. So what we've done over the last several decades is look at how these injuries occur. And this was the Quatman twins pushed a lot of this data forward during their PhDs. Basically, what we did is we took in vivo biomechanical full 3D motion analysis data of athletes, both prior to ACL injuries and after ACL injuries. We fed them into in vivo cardiac cadaveric studies that looked at could these kind of loads actually rupture an ACL in the lab. And then we fed that both types of data into in silico state-of-the-art computer models and demonstrated whether or not we could predict what kind of loads and who is at risk of rupturing their ACL. We fed a lot of data into these models, one being, as is here, MRI data, which shows bone bruises. And again, these bone bruises, if you follow them, they happen most predominantly in the lateral compartment on the posterior tibial plateau, the anterior femoral condyle, which again, that's when the high impact occurs, again, showing this mechanism of abduction, so lateral compartment, anterior translation, so posterior tibia, anterior femur, and internal rotation. So in combination, what you get is ACL rupture. So we've used this data in many studies to develop very high-level computer models using cartilage pressure distributions, using MRI, and basically what we have is forensic data for, as I just showed you, how an ACL injury occurs. So basically these results show a valgus collapse as the major ACL injury mechanism combined with tibial abduction, anterior translation, and internal rotation. So each one of these different luxations and rotations increases strain on the ACL. As you can see, anterior shear increases strain relative to the, we've done everything combined, looking at comparisons of different ligaments. Each of these increases strain on the ACL. But when you combine all three together, abduction, anterior translation, internal rotation, what you get is high enough strain to rupture the ACL. So even if you look at clinical tests, which are attempting to forensically reproduce the ACL injury, what you see is the most specific test for ACL rupture is a pivot shift exam. And what do you do during a pivot shift exam? The clinician applies a knee abduction, internal rotation, anterior translation force. That is reproducing the injury. So there's strong level 1 evidence of this mechanism of coupled tibial abduction, anterior translation, internal rotation, in vivo data, in silico data, in vivo data, literally hundreds of studies from our lab and many others demonstrating this. So this is the injury mechanism, and this is important because if we're going to figure out how to reduce the risk of these injuries, we have to know the mechanism. And importantly, anything that we can do to reduce one of these three rotations or luxations is going to reduce the risk of an ACL injury. So what we've demonstrated over the last couple of decades now is that there are parallel neuromuscular imbalances that relate directly to this injury mechanism. So this knee abduction relates to a neuromuscular imbalance I'm going to term ligament dominance. Low flexion relates to quadriceps dominance, the single leg aspect to the mechanism to leg dominance, and this increased lateral trunk motion to trunk dominance. This is an NBA player. Some of you might be familiar, coming from the Boston area and the Celtics. Here he is. He's got a single leg, valgus on an extended knee, demonstrating leg, ligament, and quadriceps dominance. We also, using these biomechanical epidemiologic studies, developed tools. So, for example, we took an entire team of young basketball players. At that time, I had labs at University of Kentucky, Cincinnati Children's Hospital, and Ohio State. And we brought them into all three labs and tested these young athletes across and in all of these laboratories just to look at the reliability, reproducibility, and validity of our measures. Now we go from young female athletes to an NBA athlete again. Valgus, extended knee, ligament dominance, and quadriceps dominance. What you see is boom, straight, and we'll talk a little bit more about this. So knee abduction relates to ligament dominance, low flexion to quad dominance, single leg to leg dominance, lateral trunk motion to trunk dominance. So these young athletes, thousands of young athletes that we screened and we fed in, this was the first initial study that we, on prediction, that we published now 20 years ago, where we showed that those young athletes who went on to an injury had about 8 degrees more abduction of their tibia relative to their femur and about 10 degrees less flexion. Really good predictors. Now, in the transverse plane, rotation is a little difficult to pick up because you're only talking a few degrees within error. But if we look at just the knee abduction angle, just that distal tibial abduction angle relative to the femur, the X's are those that go on to an ACL injury. As you can see, this is actually quite sensitive and specific. It's about 80% sensitive and specific for those athletes who go on to an ACL injury. But more importantly, if you look at the spread of the data, somewhere between a half and 2/3 of these young athletes, these are young female athletes in high school and college, at relative risk of an ACL tear. So again, looking at these neuromuscular imbalance, ligament, quad, leg dominance, and trunk dominance. This is my favorite sport. I don't know if many of you have seen this or not, but it's WWE and female athletes. She just ruptured her left in the back. She just ruptured her left ACL. What you have to do is notice, look on the left-hand side, see that the glute activation, see that pelvic drop, see that trunk movement. She ruptures her ACL. So no matter what sport you look at, if you're looking at many different sports, for example, see if we can get some of these to play. So this is team handball, which is a really high risk sport for ACL injury. What you see is this common mechanism of each one of these athletes is attempting to stop with a flat foot, pivot across their body, perturb their trunk, fake out their opponent, throw the ball around them. And basically what they're doing is recapitulating the injury mechanism of this trunk perturbation, whether it's induced by themselves or someone else, combined with a flat foot with a relatively straight knee and valgus because of the trunk movement over the lateral to the leg. Now, one athlete that we know is relatively resistant to ACL tears is a gymnast because they have great core control over the foot base. But even a gymnast, if she loses control of that center of mass and where it is relative to the foot base, she's in trouble, ruptures her ACL. So this is what it looks like in the laboratory. Basically, what you get is you get an athlete dropping down off a box, and what you see is you get this asymmetric torque on both sides. And basically, you see the same thing you do on the court, which is flat-footed, You let the trunk go lateral to the hip and knee, which creates a torque, a abduction torque at the knee, adduction torque at the hip, and you rupture your ACL. Now, what we showed in the lab is we could actually change this profile, that we could alter and bring those forces across the center of, in the center of the knee, and give the athlete the analysis and feedback to demonstrate this is what you're doing. Bring those forces across the center and the hip and the knee, flex your hip and the knee. Do not allow excessive frontal plane motion. Do not allow excessive internal rotation, and you can reduce the risk of these injuries. So again, this is very important. The trunk is absolutely crucial. This is a study of almost 300 Yale athletes where we looked at core stability and proprioception. And actually, Jacek Kolowicki, who did these original studies, was looking at the association between trunk proprioception and control and future risk of low back pain in this cohort of Yale athletes. And what they showed was there was a slight association. They published this in the journal Biomechanics. I read the paper and I called up Jacek, and I were actually sharing a PhD student at the time, Billy Zazalak, and I said, do you guys have the data for knee injuries on this, not just low back pain? And we checked with the team physician and the athletic trainer, and they'd collected all the injuries. So this was kind of a serendipitous, very cool study because there were no biased preconceived notions or hypotheses directed at the association between trunk neuromuscular control or trunk proprioception and future knee injuries. It was strictly looking at low back pain. So what we found post hoc was those athletes who could not reposition themselves, didn't perceive the center of mass well and where its position was in three-dimensional space, had significant risk of knee, ligament, and ACL injury, especially if they were female. So we go back again to the NBA, and what you see, this lateralized trunk, the control of the core, again, in this case, perturbed, but regardless, what happens is when you get a ground reaction force from the foot is directed at his center of mass, as it is in any athlete, as he lands, ground reaction force from the foot. Now, when you have a high ground reaction force, high distance, force times distance is torque, you have a high abduction torque that ruptures his ACL. And this was a series of studies we did with a large group in Philly and Boston and at the NIH. And basically we looked at every ACL injury video that we could find anywhere. And basically in every case, we saw this lateral trunk lean that led to valgus collapse, that led to ACL injury. So what we did is we developed tools. So tools for primary prevention. We just did baseline evaluation using simple wall jumps and looking at an athlete's body habitus, control, hip and knee, as they did just simple techniques. And then as we developed, for example, she's preparing for a broad jump, we looked at those athletes who actually use their muscular system to actively recreate this dynamic valgus position. And those are the most difficult to retrain and reduce the risk. And basically what I'll use is an analogy here. So the idea is once these athletes, high-risk athletes, have growth, okay, so for example, males and females are both at relatively low risk of an ACL injury when they're pre-puberty or pre-adolescent. Once adolescent hits, now adolescence hits in young girls about a year and a half to 2 years earlier than boys. So they get these longer levers. They have more body mass, so they have higher forces. And if they don't have a relative increase in power in their hip and knee musculature and strength, they get a decrease in neuromuscular control. They get an increase in dynamic valgus. They get an increase, a high joint load, this increased knee abduction moment that I've been showing you throughout these studies, and increase injury risk. So if we use a car-based analogy, just to simplify this, so boys and girls start, say, with a Prius body of the car, a Prius chassis, let's call it, with a Prius engine. And the engine and the chassis are matched. The engine has enough power to control the chassis. What happens after the growth spurt? So you got longer levers, the tibia and the femur. You got a longer trunk where there's more mass. The mass is displaced higher off the ground. So it's almost like you have more mass on stilts. So it's higher, more difficult to control. Now, we've done these studies, and I can show you these in many different ways. We've done these studies longitudinally in the same athletes. We've done these cross-sectionally in massive number, thousands of athletes. It all looks the same. What you get in young females is you get increased chassis. So you're going from, say, a Prius to a Malibu car. So you got a bigger chassis, but with somewhere between a Prius and a Malibu engine. So you get a mismatch in relative power output compared to the size of the chassis. Whereas in males, what you get is you get a bigger chassis, say even larger than females on average, say a Cadillac sized chassis, but you get a disproportionately more powerful motor or engine. So you get a Cadillac chassis body with a Porsche engine. Now, how do I know that? It sounds ridiculous. Well, here's how we know. Great measure of whole body motor power is vertical jump height. And we do vertical jumps on all of our athletes. It is the most specific and the most reliable and reproducible measure of whole body power that we can utilize. And basically what it shows is whether we do this longitudinally or cross-sectionally, as young girls grow, as they go through adolescence, their vertical jump stays on average about the same. Whereas males, though they're getting more massive and their center mass is even going higher, so they've got longer stilts, they jump higher. So they displace that greater mass to a higher level. In other words, their engine, their motor, is more powerful relative to their body or their chassis. And this is what I'm talking about here. Now, what I've been talking about is bad news for females relative to the males. The good news is what you all do, what you can do as physicians, athletic trainers, physical therapists, is you can increase that motor power. It's modifiable. And that's the good news in everything I've talked about here. All these neuromuscular imbalances, they're all modifiable risk factors. They can be changed. And we've demonstrated they can be changed. And we've demonstrated along with that, the risk is changed. So we did a series of studies. So this is an athlete doing our drop jump vertical test. So they're dropping off a 30.5 centimeter box and they're rebounding a basketball that is set at their maximum jump height. So they're focusing on trying to pull that ball down, because if they can't get to the midline of that ball set at their maximal height, they cannot rebound that basketball. We're focusing on the entire body. And basically what we're doing here is this is a computer model where we show when her femur and tibia go red, she's above the 25.25 Newton meter threshold of high risk for an ACL tear, as you can see occurs. As you can see, the blue ball within her pelvis that's her center of mass, and we're also tracking that as well. So we realized that a lot of people don't have a multi-million-dollar motion laboratory. So what we did is side by side, we did 3D motion with the video. So we just took straight video, just as you get these were high-end camcorders at the time, but any iPhone is just as good now. So we did side by side, and we looked at the peak load in these athletes, and we did this longitudinally as these athletes grew. This was, again, an entire school system, entire county school system of all the young athletes playing the high-risk sports of soccer, basketball, and volleyball. So literally hundreds of athletes. This is an example of one young basketball player. She has long levers. So tibia length turns out to be a pretty good predictor of relative risk of an ACL. So basically, this is generated with a program called R, a statistical program. She gets 79 points for her tibia length. One side, asymmetric motion. She has 3 centimeters of increased knee valgus motion on the non-dominant leg versus the dominant, and she gets 13.5 points for that. She has a stiff landing, so she goes through relatively short arc, 56 degrees knee flexion range of motion. She gets another 9.5 points for that. Body mass is almost always a predictor. That's simple physics. It's true. The bigger you are, the harder you fall, the harder you hit, the more force you have. She gets 20 points for that. And then the only thing we used outside of a camcorder was a dynamometer, and we showed relatively quadricep dominant, stronger on the significantly stronger 1.2 quad to ham. She gets 8.5 points for that. Now, interestingly, it's important that you look at the length of the rulers here, because the length of the ruler is directly proportional to the predictive capacity of that. So what predicts? Those lever lengths, the tibia length, that valgus knee, knee and hip collapse inward, knee flexion. Those are the big predictors along with body mass. Quad ham, we can basically put in a factor here so you can do video motion and not use a dynamometer, because it contributes. Quadriceps dominance contributes here as far as strength goes, but it's not a major predictor, as you can see indicated by the length of that ruler. But what we could do using those 5 predictive variables, we could say with 97% certainty, this person was a high loader and increased risk of an ACL tear. Now, when we did side by side and looked at the 3D full motion of that body, her actual load was 48.5 Newton meters, which was nearly double the 25.25 Newton meter cutoff for relatively high risk of an ACL. So why is all this important? Here's why it's important. Basically, what we showed in multiple studies and multiple meta-analyses was that if you took interventions that targeted these predictors, reduced that valgus load at the hip and knee, reduced the amount of quadriceps dominance, in other words, more flexion at the hip and knee, and reduced internal rotation, you could significantly reduce in all athletes, about a half, and in young female athletes by 2/3 your risk of an ACL tear. This is the most important slide of the talk right here. How do we make an athlete less vulnerable? Well, we address the mechanism. How do we do that? We attack the modifiable risk factors that are directly related to that mechanism. Knee abduction. We work with biomechanics and technique. primarily with plyometric training. Low flexion, we do a lot of power training, and we really recruit the posterior chain, the glute and the hamstrings, the big agonists of the ACL, the big helpers. Single leg part of the mechanism, a lot of balance and symmetry. So we start double leg plyometrics, we move to hops, single leg plyometrics, and believe it or not, if you work single leg, you actually create greater symmetry. Then we bring that back to double leg plyometrics. And then we do a lot of core stability training, but it's a lot of foot based so that it's going to translate onto the court or onto the field. So what did the meta-analyses show? Well, they showed that you could reduce the risk of all ACL injuries by half. You could reduce the injuries risk in young females by 2/3. What were the commonalities? These were the commonalities. Every study that reduced the risk of an ACL tear had plyometric training combined with biomechanical analysis and technique with feedback about how their movement patterns were. So there was some criticism when we first published this. This is from a German group in the Journal of Bone and Joint Surgery, because people said, well, maybe this is just a publication bias. Maybe this is not valid. Maybe it's not reproducible. So they looked at all the studies, and you can see this middle. This was our original study. This goes back 25 plus years now, but a lot of these studies were more recent. And basically what this funnel plot analysis shows is this is that 2/3 relative risk line reduction. As you can see, all these studies hug this line very closely. Now, if this was a publication bias, in other words, only those studies that showed a positive effect of this neuromuscular training would be included in the literature, because otherwise, if it was a negative finding, it wouldn't get published. If that was the case, you'd have studies outside this funnel. In this case, it's valid, it's reproducible, and it's not a result of publication bias. This is a study that Kate Webster and I published in the Journal of Orthopedic Research. It won the Best Clinical Paper of the Year award that year. And basically what we showed was, so in our original study, this was 20 years prior, we showed in a cohort of a large cohort, but not this large. This was thousands of subjects. So this was a meta-analysis of all the meta-analyses. I call it our inception analysis of ACL injury reduction. And basically what it shows 20 years after that initial study is the exact same thing. You can reduce the risk of all ACL injuries by half, and ACL injuries in young female athletes by 2/3 with this targeted neuromotor training, which is crucial. So here's the algorithm. This is our precise rule for reducing the risk of these injuries based on the mechanism, based on the neuromuscular imbalances related to the mechanism, and based on the targeted interventions that directly address the mechanism and the neuromuscular imbalances. What's the problem? There's a high risk of ACL injury in specific athletes. What's the algorithm? Technique, plyometrics, dynamic balance, dynamic core and strength training. So here are our training components. Biomechanics, we use safe and effective technique and biofeedback. Plyometrics, which is importantly, plyos are neuromuscular adaptation. So what you're doing is teaching that athlete to have their lower extremity, their hip and their knees in good, solid, straightforward, sagittally plane alignment. So you're flexing and extending in the sagittal plane, which is where the primary movers, the glutes, the hams, the quads, control the knee joint and absorb and dissipate those forces. And you do it very quickly, and you teach them to turn that around. And and move that center of mass where you go from where the center of mass is descending. So this is the amortization phase. You're going to shorten that into accelerating upward again very rapidly. So it incorporates all the parts of the stretch shortening cycle, and you do it very quickly. So dynamic functional balance and strength training are incorporated, where you get functional speed and multi-directional power in all three planes of motion. And it also incorporates core stability, but you're going to do kinetic chain control, balance, perturbation. This is a good example of this is an assisted Russian hamstring curl with a band, where you get not only the eccentric, the downward motion, but the concentric as well, firing up that entire posterior kinetic chain. I love those exercises, by the way. They strengthen, but more importantly, they recruit the entire posterior kinetic chain. So we did a meta-analysis when 12 studies existed, and we showed, again, this was our first study in 1999. We showed a relative risk reduction of about 2/3. And at that point, with the meta-analysis of 12 studies, showed the exact same thing. So again, this is the most important study. This is the most important slide I'm going to show you. This is how you use that mechanism, those neuromuscular imbalances that you can identify, and that targeted neuromuscular training to those neuromuscular imbalances to reduce the risk of an ACL. Knee abduction, use biomechanics and technique. Low flexion, plyometric power, especially increasing that ham quad ratio and increasing hip and posterior chain strength. That's important, but more important than strength. Most athletes have enough strength. What's more important is recruitment. You have to recruit. The glutes are the biggest, most powerful muscle in your body. They not only control the posterior position of your femoral head, they control where your knee joint is in space as well. Turning on that posterior chain, the entire hip complex, turning on those hammies, which are your primary agonist of your ACL, absolutely crucial. You do a lot of single leg on flat foot balance work, developing, again, double leg plyometrics, moving to single leg, which is going to, believe it or not, create greater symmetry, back to double leg to make sure that symmetry exists, and then controlling the center mass of their foot base so that you get this dynamic core stability and strength that's going to transfer. It's got to be able to transfer. You got to do things that incorporate balls, that incorporate perturbations, that incorporate chaos, just like they're going to experience out on the field or on the court, or it's not going to work. So my argument is going to be this. If we can do this, if neuromuscular training, we showed this in the 90s, if in the laboratory we can show that targeted neuromuscular training increases neuromuscular control of the joint, and then you can show out on the field that this actually reduces the risk of knee and ACL injury, then these mechanisms are primarily neuromuscular in nature. And there are other, I'm going to show you some genetic data. There are other factors here. So what we know is we can reduce the risk between half and 2/3, right? That means somewhere between a half and a third of this risk is non-modifiable. However, this is good, especially in orthopedics and sports medicine. You see an effect size of 50 to 67%. You don't get an effect size like that. You don't get an effect size like that with surgery. This is really useful. And the good news is this is modifiable in nature. This is huge. Again, this is real. Now, there are people that will argue with me. There are, and I love to argue. If you guys want to argue at the end of this, let's do it. But we have a ton of data here, overwhelming evidence, as good as of evidence, as strong, reliable, reproducible, valid evidence as there is in the orthopedic and sports medicine literature that shows that knee abduction, internal rotation, and anterior translation cause primary, and there's a lot of data for secondary injury risk as well. And there are multiple neuromuscular studies that if you address these, and this is in all kinds of data, whether it's video data, whether it's cadaveric data, whether it's we have data now in virtual reality that shows the same thing. This is the mechanism. This is Shay Ralph. I believe this was her third ACL tear. And I gave a talk out at, I think it was in Vail. It was a AAOS course to surgeons. And I said, believe it or not, do you think you can predict athletes at risk? So Shay Ralph was at UConn at the time. I believe as point guard, she led them to 3 or 4 national titles. And that was her third ACL tear. And I said, she went on to 5 ACL tears and reconstructions. And a surgeon in the back raised his hand and said, Hewett, you're wrong. And I said, that's impossible. I've never been wrong in my entire life. And he said, you're wrong this time because I just reconstructed her ACL for a 6th time. So do you think you have athletes that are at relatively increased risk and you point them out? I think you can. And I'm going to finish up the talk here with what we did is these same prospective studies. And a lot of my students and postdocs worked, a lot of people, a lot of surgeons worked on this as well. But I want to give credit to Steph DeStacy, Mark Paterno, Laura Schmidt, Greg Meyer, Kevin Ford, Chris Kading, many, many others. And basically what we did, prospective biomechanical epidemiologic studies. So we had followed these athletes for a decade and then started intervening. And then we started tracking who was actually getting a second tear. And we just kept following them. In the game. This is Derrick Rose tearing his ACL. That's a $22 million a year player who about 11 months out, the Bulls the next year were in the playoffs and he wasn't playing. And they basically roasted not only the team, why isn't our $20+ million point guard playing in the playoffs, but what's up with the doctors? So they actually even roasted the medical team at that time. And I was actually brought in as consultant here. He just said, my involved side doesn't feel right. It's not the same knee it was before, 11 months out. And that's where we got pulled in and started working with the NBA. So what we know is that there are lots of problems. And we wanted to look at this data and keep following these athletes and say, okay, what predicts a second or third or fourth ACL injury? And we've been doing this for decades, looking at this. What we know is that the ACL is not just, so this is your ACL, it's proportional to the size of the first 2 digits of your pinky. It's very strong. In Cincinnati, we tested it and we said it takes 1,800 newtons to tear your ACL apart. That's about 450 pounds. And in New York, Pete Torzilli and their group did parallel studies. They said, no, it's 2,200 newtons or 500 pounds. You know, even cadavers are tougher in New York City than everywhere else in the world. But they looked at that and basically, so it's this elastomeric tissue, but it's much more than that. It's richly innervated. It has all 5 types of mechanoreceptors. And what happens when you pull this elastomeric tissue apart and you have mop ends? Basically, it has 5-way sensors in your knee joint that sense not only the 3D position of your knee in space, the center of rotation of your knee in space in all 3 planes, but it also has neural inputs that have afferent, efferent feedback loops that tell for example, the hamstrings, hey, there's force tugging on my ACL, turn on the hamstrings to take down that force. So after these mop ends occur, is that sensor, does it ever return? I think what you're doing is actually developing extra articular controllers to sense where that knee is in 3-dimensional space. And this is a series of studies we did in dogs, actually. This one looking at ACL innervation and looking at joint function. And there's this loss of sensory function that leads to a lot of problems, joint dysfunction, post-traumatic OA. And this is a series of studies we did where we showed, gee, if you go back to the same level of sport, your risk of another ACL after a year is a quarter, and after 2 years is a third. And people said we were crazy. But then these groups, Kate Webster and Julian Feller's group, and Leo Pinchesky's group, and Sydney, they have Australian rules football, which for many reasons is the highest risk ACL sport there is, because again, you do these speckies where your center of mass is perturbed and it goes lateral to your hip and knee, and you have this collapse because you're landing from these high jumps and basically recapitulating the ACL injury mechanism. They show the exact same numbers that we did, which is, again, scary, but it's also gives you some confidence in what you're doing. And basically what we showed is we could predict, just with hip internal rotation moment and knee abduction moment, we could predict second ACL injuries. This is the hip internal rotation moment impulse, where we show this is those athletes that do not go on to a second ACL. This is zero. So there's no net. You're basically using the glutes and the hip complex to externally rotate your hip all throughout landing. Whereas those that go on to an ACL, second ACL tear, have a negative, meaning they're allowing the ground reaction force to internally rotate and adduct their hip, abduct their knee. And this is the prediction power. Greater than 80% sensitivity and specificity just using that net hip internal rotation moment impulse. Watch Baron Davis here rupture his ACL graft. So I just showed you in a cohort of thousands of individuals. Now look in one individual, an N of one. Now, what did I say? Net hip internal rotation moment impulse and knee abduction. Ruptured his graft. Here is RG3, Robert Griffin III. He was in the playoffs. They put a derotation brace, which I don't know how you prevent. Again, if we go back to the mechanism, let's say about 8 degrees of distal tibial abduction, about 5-6 millimeters of anterior translation, and maybe 5 to 6 degrees of internal rotation. Is that brace on the outside of his leg going to resist that? Well, he ruptured his ACL in the first game of the playoffs. But then if you go back, this is his rookie year, to the combine, they asked him to do a max forward broad jump. What's he doing here? He actually has active valgus. He's the one of the toughest to, because he's actually winding up, storing energy, and then taking off using that valgus hip and knee mechanism. That increases risk. So again, young patients are at significant risk here. A quarter after 1 year, a third after 2. And we're looking for these athletes, the ones that use their knee like ball and socket joints, because if you just look at the relative risk here, hip internal rotation moment, a net negative. And in other words, they're allowing the ground reaction force to internally rotate their hip and abduct their distal tibia, 8.5 times greater ratio of injury. That frontal plane knee valgus moment, 3.5. Differences in quad relative to hamstring strength side to side, 3.5 greater risk. And then a stiffening on balancing on the involved side, about 2.5. So we could predict with those 4 variables, 94% of the variability for having a second ACL tear. This is the ROC curve. If you look at ACL tears, we're asking her to sway back and forth. This is at a slow speed, and then we go to fast speed. Track that rectangle as it moves on the biofeedback screen toward and away from her. And we brought in another set of participants who were teammates who had never been injured. Same basic height, same weight, same team, same position usually, so we could control for all these biomechanical variables. This is what uninjured control. She was moving at 20 hertz, then we go to a fast speed. This is what normals look like. So what ACL injuries look like. They're more variable and more out of phase at the slow speed. And then what they do is you go to the fast speed, they actually lock down the degrees of freedom of the joint. They can't sense it or control it because they've lost that ACL sensor. Here's what happens when you test someone who's going to go on to a second ACL injury prospectively. They're exactly opposite in pattern. So at relatively slow speed, the joints, the lower extremity joints, hip and ankle are 180 degrees out of phase with one another. And then they have to lock it down when you go faster. They lock down, especially the knee joint, because they can't sense it. And this is a modeling system, nonlinear dynamical systems. This is someone who's never had an ACL injury. The lower extremity joints are very contiguous and very linear. Someone with an ACL tear, that relationship breaks down. Someone who's going to go on to a second ACL tear, you break down the linearity and synchronicity of those lower extremity joints. So the outcomes after ACL tear are questionable. They're very challenging. There's these abnormal neuromuscular strategies. There's this high prevalence of osteoarthritis. There's this unacceptably high risk of a second tear. So what we're currently doing is using new surgical approaches, new neuromuscular training approaches, new targeted interventions that incorporate everything from non-marker based motion analysis to virtual reality to force plates to IMUs all together to track these athletes, see what their progress is, to see if we can get better outcomes. And we target these risk factors using this prevention training paradigm where we address lower extremity 3D biomechanics, independent and combined exercise, progressed phases, slowly adding degrees of freedom, volume, speed, perturbations, so that we can control before they progress. Otherwise, you end up with a $20+ million athlete who lands awkwardly, meaning his center of mass goes lateral to his hip or the knee, and he tears his graft. So again, that frontal plane is key. So we start with lateral jumping progressions. We start proximally, work distally, and then we incorporate that preventive biomechanics approach. And we get the entire team, from the orthopedic surgeons, the primary care physicians, the physical therapists, athletic trainers, the scientists, the research team, and make sure everyone's on the same page and know where that athlete is in the risk profile and get them the interventions they need before the injury occurs. Going back to Carmen and Katie, I started out the talk with, this is them, these two identical twins who both ruptured their ACL. At a fun family picnic, we collected blood and did the genotypes on the entire living relative and the entire pedigree for the family. And basically, this is their father, Tom, and his identical triplet brothers, all three bilateral ACL tears, and a couple of them have passed, one with myocardial infarction. Here's my pedigree. I want to, as I always do, I want to dedicate this talk and everything I do to my mom and my 6 sisters. Best thing that ever happened to me growing up. Thank goodness for them. I have no idea where I'd be at this point without them. I have written a book on this topic. I don't make a dime off of it. All the money goes to ACL injury risk reduction at the AOSSM, the American Orthopedic Society for Sports Medicine. I want to thank you. I appreciate your time this evening, and here's how to get a hold of me. You're welcome to ask me any questions. I'm very open to questions, or you're more than welcome to come after me on X or any of these other media. I love to discuss where we are currently and how we might move forward from here. Thank you for your time tonight.
Hey, Tim, thank you for your time. That was excellent. We're a little bit over time, but that's fine. Couple of things. I mean, first of all, a lot of these things, and that's why I mentioned your bibliography earlier. A lot of the things that we now take for granted in ACL risk factors and prevention is obviously based on a lot of that work that you just presented. As you mentioned, oftentimes by the time we see these patients as surgeons, it's a little bit after the fact. They've already torn the ACL. And I know with, the PEP program, FIFA 11, I mean, there's so many ways that we've tried to intervene earlier and try to prevent things. But I was a little bit discouraged because I was thinking, hey, maybe there's a way to, look at these kids when we do these pre-participation physicals and see who's at risk. But then it's also already a little bit late, right? Because it's right before the season. And when you showed that picture of RG3 at the combine with his kind of dynamic valgus, even at a high level athlete who's like the third pick in the draft, and I think Heisman Trophy winner at the time. I mean, if those people are, that level, we can't fix it and it doesn't matter and they still get drafted. I mean, what can we do realistically, right? Because we see these patients very late in the game, so to speak, prospective patients right before the season at the physical or at the draft. Combine, or we see them after they've already been injured. So what are your thoughts? What's the most bang for the buck that we can provide as orthopedic surgeons?
Yeah, so I've been to the combine many times. I was there and spoke to the NFL team physicians this year as well, just this past March in Indy. And I get this question asked all the time. And the thing about RG3, for example, he actually winds up. I want to write a paper on this. It's a paper that I've thought about for quite some time. Some of the best athletes use that technique to actually store not only their active muscular power, but their fascia, the ligament, the connective tissue in their lower extremity and trunk to wind up and then unwind it. I can tell you those athletes, and I call those with active dynamic valgus, they actually use that on the takeoff, not just the landing. It makes him a very high risk athlete, makes him very tough to train. What I can tell you, I don't know at what point, basically for young athletes, the best point to get there is their worst point when they're going through adolescence. And you see this all the time. For example, especially in young females, you'll be coaching or you're the PT or team doc or whatever. Best player on the team, young girl, will start going through a growth spurt, and she'll become not the best, maybe maybe the worst. And what they're going through is this growth spurt. The body's changing, the chassis is getting bigger. That's the time to give them that more engine power. So the earlier you can get to these athletes, the better. But especially it needs to be during that time of the growth spurt of adolescence. That's the key to reducing risk. Now, again, in these NBA and NFL athletes, the thing I'll say to that is when these athletes train, they're training throughout their career to kick a ball as far as they can, throw a ball as far as they can. Well, what happens there when you're trying to maximize a movement? What you're doing is maximizing activation of the agonists, the muscle agonists of that movement, and you're maximizing the shutdown of the antagonists of the movement by definition to get the maximum movement of it. So what you have very often in the highest level athletes are the highest risk athletes. They've actually made themselves more and more asymmetric, and they've made themselves at great risk. The best you can do is screen, analyze it, develop a risk profile, and then incorporate in their training some targeted interventions that are not going to reduce that risk by 100%. Here's my take on it. We can reduce the risk in young adolescent athletes between half and two-thirds. We can reduce risk of second ACL tears in that population later on, probably by half of that, somewhere between, let's say, half and a third. And then you, oh, well, let's say a third and a quarter. And then, you know, high level athletes you're talking about, they're probably somewhere in that range, even a little bit lower. But if you can reduce the risk in a 25 a year $1 million athlete by 20%, that's a win for a team. There's no doubt.
Rich Wilk has his hand up. Rich.
Yes. Hi. Nice to meet you. And that was a fabulous talk. And kudos for all the amazing research you've done. Comment and then a question. You've shown a ton of videos of some of these high-level athletes who are blowing out their ACL grafts, and you would think that of all the people who might be educated and who might be trainable to not have those valgus moments, the abduction moments you comment on, or internal rotation moments, yet somehow they're still having these re-injuries. The question I have is, what's the value, if any, of a brace? And we know that there's not a lot of data showing that braces or prophylactic braces do anything to prevent re-injury. In terms of lessening the risk of the abduction, the knee abduction valgus moment, is there potentially a benefit there?
So, well, the first thing I have to ask, and I'm sure I won't get an answer, is are there any brace reps involved in this call? Because I get myself in trouble very, very quickly here. If there is, again, as I said, when you're talking about a cylinder, basically your thigh, your knee, and your shank, and you're wrapping it in some kind of cylindrical construct that in between the bones is muscle and fascia and fat and skin. And you're talking about relative increase in movement to tear your ACL by about 8 degrees in the frontal plane, about 5-6 millimeters in the sagittal plane, and maybe 5-6 degrees in the coronal plane. My answer is biomechanically, probably not. Now, if there is an effect of the brace, and this has been shown in RCTs with knee sleeves, is if in anything, when you lose that controller, that sensor in your knee, that ACL that has all 5 types of mechanoreceptors, anything you can do to sense the 3D position of that center of rotation of the knee joint in all three planes could be positive. And I think if anything, that's what a brace may be doing. It may be giving you through the skin a better sense of where your joint, a better proprioception. If there is an effect, that's where it would be, not at the biomechanical level.
Okay, great. Thank you.
You're welcome, Rich.
Gio Medina.
Hey, Dr. Hewett, thank you so much for your talk. I have a question regarding these biomechanical variables, specifically quad dominance and the contribution of the hamstring to decrease anterior tibial translation. What are your thoughts on graft choice based on all these biomechanical variables?
Yeah, you're asking me to stand up on my soapbox now. Given what I just say about this, I do not recommend, obviously, I do not recommend a hamstrings graft. I think that hamstrings is a absolutely crucial helper. No, a lot of I mean, many surgeons that I respect do hamstrings grafts. And, again, what they'll say to you is, well, you have to individualize every patient. There's a lot of factors that affect this. But I say, there's no doubt now. There's no doubt from the registry data, from Scandinavia, from Europe, that hamstrings graft fail more often. They do. So I would say, if you can, if the individual has anything that's not gonna, really push you toward a hamstrings graft, say for instance, existing, inflamed anterior knee pain, that type of issue, then don't use a hamstrings graft. And definitely in the young athletic population, do not use an allograft. Allografts are okay for somebody that's maybe going to play weekend tennis at the club, but not a young athlete in cutting, pivoting sports. You're going to want to use a bone tendon bone or a quad graft in young, active, cutting, landing populations.
So in that same line of thought, do you think the quad might be a great option because it decreases the quad dominance?
I'm
The
actually
ratio.
I'm a big proponent of the quad. And there are those who will argue with me. I do think at this point that the problem we have with quads is we don't have long enough follow-up at this point in most clinics. Most clinics now are, even those that got in early, are, maybe five years, and that's the minimum amount of outcome time. But I think, Don Shelburne used to push that forward. So Don Shelburne, guys like Bill Garrett, they believe and believed that the biggest problem with ACLs was quad dominance, that what you had was this massive quad contraction that would lead you to a really straight limb, that would lead you to a flat foot, a very high force, and a rupture of the quad at low knee flexion angles is a direct antagonist of the ACL. And that's why Don Shelburne, in his series with hundreds, if not thousands of athletes, he demonstrated that that's the reason he took the contralateral bone tendon bone, is because it kind of weakened the quad on that side. And when he did, he said it evened things up and reduced the risk of a second tear. So there's a lot of interesting theories out there. I think the quad graft is a really good option, but we still have, I throw that out there on X, and I will have surgeons come after me big time to say, you don't have the data to say it yet. So we need longer follow-up on the quad grafts. But thank you for a great question. Any other questions? Again, you've got all my connection here, whether it's X or YouTube or Instagram. Please come contact me. I love the ACL. Hey,
Yeah, we couldn't tell.
Talk about it anytime.
Hey, man, that was great. We could probably talk about graft choices another 30 minutes, but we're a little bit over
At
time.
least. Yeah.
Hey, thanks again for doing this, and thanks for all the insight. Appreciate it. Thank you, Tim.
Pleasure's all mine. Thank you so very much. Take care, Simon. Take care, guys. Bye now.
Thank you.
Bye.
Bye-bye.